We're going to stay with health matters, and here are some interesting numbers for the HSE to ponder. Almost 1 in 7 visits to the GP and 1 in 12 visits to emergency departments could be dealt with by a local pharmacy, according to recent UK research. These numbers were quoted by Kathy Maher of the Irish Pharmacy Union, who also said minor ailment treatment costs in an emergency department are 5 times that of a pharmacy and 3 times that of a GP surgery. Brian Lally was at the IPU conference today.
We will never get on top of our health spending if we don't tackle chronic disease, obesity, all those things that make us sick.
That was the Health Minister, Leo Varadkar, on a recent edition of Today with Sean O'Rourke, speaking about the inexorable rise of health spending in Ireland. One of the things that might alleviate that spending a little bit was the topic of a conference today in Dublin, the role of the pharmacist in self-care. Kathy Maher, President of the IPU, explained to me the concept of the Minor Ailments Scheme.
A Minor Ailments Scheme will aim to provide non-prescription medicines to patients with a medical card in a timely fashion. There's review on minor ailment schemes in the UK showed that about 13.2% of patients in an A&E setting should have and could have been dealt with in a community pharmacy. At the height of our trolley crisis, we had 600 people on trolleys. That's 80 people could have been dealt with in the community pharmacy. So we'll go a long way to addressing that issue.
John Chave is General Secretary of the Pharmaceutical Group of the European Union. I asked him for the international perspective.
Many European countries, in fact virtually all of the European countries, are cutting their health budgets, including their pharmaceutical budgets. Our population is getting older, technology is getting more expensive, and that inevitably means more cost. So it's 2 waves, cuts now and more expenses to come. Many countries are recognising now that they need to use their trained healthcare workforce to the best effect possible. In some countries now you're seeing, for example, services to help patients comply with their medicines regime better. Many patients don't do this properly, and obviously that's more cost for the health system. If we could get patients to take their medicines better, that would be a huge saving and a huge impact on the quality of people's lives. If we can encourage pharmacists to take more of the burden, if you like, of self-care, then all the evidence shows that we can greatly reduce costs without having any negative effects on people's health outcomes. In the UK, the GPs accept themselves that 30% of their consultations are for minor elements or what we would call self-limiting problems, which could be addressed by pharmacists. And so it seems to me that there's a quite clear case of helping other health professionals, including obviously primarily pharmacists, take some of that burden away from GPs.
Dr. Natalie Gold from New Zealand spoke to the conference on the importance of reclassification of medicines, taking things that are only available on prescription and turning them into over-the-counter.
Sildenafil is one of the medicines that's often known as Viagra. So that's one of the medicines that we've got available without a prescription. And for women with cystitis, they can now be treated with an antibiotic by the pharmacist who's specially trained to do so. And if they fit special criteria to ensure that it's safe and appropriate, then they're given the treatments. We're seeing pharmacies now have 2 consultation rooms because of the amounts of work that they're doing that needs privacy. And in fact, I was in one the other day that had 3 consultation rooms.
Bernard Duggan is a Dublin-based pharmacist, and it's fair to say that he's embracing change with open arms.
You can now go into your local community pharmacist and get your flu vaccination. A woman can go in and access emergency contraception, and hopefully today we've seen something like the introduction of a minor ailment scheme. Every town, village, every high street has a community pharmacy that has a community pharmacist in it who is aptly qualified and is the medicines expert and is able to advise patients on their medicines and on minor ailments, treat them for those conditions and offer them advice to them, or if necessary, if it's more severe, to signpost them on to somebody who will be able to help them with their condition.
I suppose we have to remember the pharmacists are the medicines experts, so we do know what a safe and appropriate use for medicine is, when a medicine isn't appropriate, and when to refer on to the GP. So patients' time is going to be improved. GP's time for the more complex cases are going to be improved, and A&E departments aren't going to be as clogged up.
Patients will be able to come in, speak to their pharmacist, and then we all have consultation rooms as well in which we can advise the patients appropriately on how to use that medicine correctly so that patient outcomes are improved.
One of the things that pharmacists do, which is generally unrecognised, is they point people towards other forms of healthcare. Patients will go in and the pharmacist will say, well, I'm very sorry, there's nothing I can do, but you should have that seen to by a professional. And that's a good service, because that's pharmacy being the first rung on the ladder of the healthcare system. And again, that helps bring people into the health system.
Dr. Colin Bradley from the Department of General Practice in University College Cork battled against a brass section in another room to sound a cautionary note.
I think GPs might be a little bit concerned because they currently are people who are involved in managing minor ailments and advising patients about their ailments, that that, as I say, are self-limiting or might be short duration and not very serious, but they still have an involvement with their GP. The GP can give them medicines to help alleviate their symptoms. So I think there would be a little bit of concern, a little bit of discomfort if that role is shifted to another healthcare professional. Again, if a pharmacist step up to the plate and look after the minor ailments, it frees up GPs to look after the next layer of complexity up, which are people who traditionally would have gone to hospital with things like diabetes that now can be looked after by GPs. But as I say, in order to increase the capacity of general practice, we need to be able to shift that minor self-limiting ailment to another health professional.
Because as John Chave said earlier, the graph is going absolutely and inexorably up of health spending.
Absolutely, and that's one of the reasons why GPs feel so stretched and so overstretched. We need the financial and remuneration models around that, so the GPs don't feel, as I say, out of sorts or out of pocket because they're having to take on this other aspect of healthcare and perhaps losing a current element of healthcare which they currently are remunerated for.